So, you've asked me to come and talk about the love of my life, which is epilepsy. Second only to my life. And so epilepsy, you know, I put forth to you that it's a very important neurological disease to learn about. It affects approximately 1% of the population. It's the second most prevalent neurological disease after headache. And some people would argue whether headache's a neurological disease at all. Approximately 1/3 of patients with epilepsy continue to have seizures despite appropriate medication. So people with epilepsy are often not cured of their epilepsy. And even if they're on medications, they tend to be on medications that cause them side effects, and are often troubling side effects. So it's a disease that needs a lot more research. A major cause of morbidity for the healthcare system is home. So a few points I'm going to start off with, and I'm going to underline this a few times in the talk. That epilepsy is a disease. Seizures should be considered something separate from epilepsy, in the sense that they're a symptom of epilepsy. So, and epilepsy is not the only cause for a person to have seizures. And we're going to talk about that. So first of all, let's start off talking about what is a seizure. So the best definition of a seizure that I can come up with is that a seizure is an event wherein a localized or distributed populations of brain neurons discharge synchronously from the receptor. And so sometimes, and most often, that causes symptoms. Sometimes it doesn't cause symptoms, and all you can see is synchronized neuronal activity on the test that we use for measuring seizures, which is called an electroencephalogram, or an EEG. So once again, a seizure is a symptom of brain dysfunction rather than a disease entity of its own. Now, what is epilepsy? Epilepsy is a chronic disorder characterized by recurrent, unprovoked seizures. So recurrent, if you have one seizure, you can't be called epileptic. If you have two seizures, you possibly can be called epileptic, but those seizures have to be unprovoked. And what a provoking factor is there are a huge number of things that can be provoking factors. If I heated your brain up to 40 degrees Celsius, 42 degrees Celsius, I think that the first thing that would happen to you is that you would start having seizures right in front of you. If I gave you huge doses of penicillin, I would bet that you'd have a seizure right in front of you. If I gave you large amounts of cocaine, you'd have a seizure right in front of you. So that person, you know, so even a normal person can have seizures under the right circumstances. But the epileptic brain is different, where not under those circumstances, which I would characterize as provoking factors, they still have seizures. And so an epileptic brain contains enduring alterations in structure and or function that predispose to seizures. So again, what can cause a seizure? Almost any local or global insult resulting in a disturbance in the brain's cortex, which is another point I wanted to put forth here, is that seizures stem from a cortical problem. It's not subcortical, although the subcortical structures can be involved in seizures. You need to have cortex to have a seizure. So as I mentioned, what can cause a seizure? Acute cerebral insults, termed provoking factors, or enduring epileptic alterations in the brain. So enduring epileptic alterations in the brain can arise, as Dr. Belief has mentioned, from genetic causes, and we'll get into this. Remote symptomatic causes, so things that have happened over time to you, like you've had a head injury, or stroke. All of those things could eventually be a nidus for epilepsy and seizures to occur. And sometimes we're still left at this point where we don't know why your brain is having seizures recurrently and in an unprovoked fashion. So again, what can cause a seizure? Acute cerebral insults. They can be metabolic. As I was mentioning, toxins like alcohol, drugs, antibiotics, antidepressants, even infections of the brain can cause a seizure. And as I was mentioning, acute head trauma or an acute stroke could cause a seizure as well. As I mentioned, enduring epileptic alterations in the brain can occur because of remote causes or idiopathic causes. Remote causes include genetic abnormalities that cause channelopathies, malformations occurring during embryogenesis, or scars or tumors occurring later on in life. So what happens in a seizure? Large groups of neurons over one or both hemispheres start firing abnormally and synchronously. And so on the right side of the page there is an example of what I was mentioning as an EEG, the test that we use to define whether this is a seizure or not. And how an EEG is performed, you put electrodes over a person's skull, and actually didn't come out very well. The top here, all of these little numbers and letters are where you would put an electrode. And then you measure the potential at these different electrodes, and then you compare the potential at one electrode to a neighboring electrode, and you end up measuring, therefore, a potential difference. So by convention, everything with an odd number is on an EEG is on the left side of the brain. Everything with an even number is on the right side of the brain. And so what you see when you measure these potential differences over time, you see this abnormal synchronization of all of these neurons resulting in a seizure. And this looks like this oscillation that we see here, and it's over the entire brain. So one of the things that I wanted to point out is how we classify seizures. So seizures can be classified as partial or generalized. And another name for partial seizures is focal seizures or localized seizures. And all of those terms mean the same thing. You can read about that in a textbook somewhere. So partial seizures occur in a localized area or a small focal area of cortex, shown in this cartoon over here on the right there. So a tendency, however, is for seizures to sometimes spread. So one abnormally synchronously firing cluster of neurons might spread to a neighboring neighborhood of neurons. And if that neighboring, if this tidal wave of synchronization of neurons over the cortex eventually gets to, starts interacting with thalamic structures here, they can spread to the opposite side. And then when it spreads to the opposite side, then it's called a generalized seizure. And so there are different ways of calling generalized seizures. They can be primarily generalized or secondarily generalized. So secondarily generalized mean that the seizure first started over some small local area of the brain and then propagated to the thalamus and then spread everywhere. Whereas primary generalized seizures probably originate in some disorder of the thalamus or interaction of the thalamus with subthalamic structures. And then just for whatever reason, there's a bundle of excitation that stems from the thalamus to the cortex, and the patient has a generalized seizure, or a generalized tonic-clonic seizure, which is the most common way that this manifests itself. And I'm going to show a video of that right here. So this is what a seizure would look like. And unfortunately, I wasn't able to cut this, but so it's going to come in 30 seconds. But it's a patient in a telemetry bed. So sometimes we admit these people to a hospital, and we wait to see a seizure occur. And we videotape them, and at the same time, we have an EEG rolling. And you can see that on her head, she has these electrodes. And so she looks fine. Nothing seems to be abnormal. And all of a sudden, out of the blue, she is seized. So that's how the term first was developed. These people were suddenly seized by some evil spirit. And in ancient times, in some places in the world still to this day, they still believe that the devil has invaded the person, and you shouldn't touch a patient who's having a seizure. So actually I spent a little bit of time in Africa at an epilepsy clinic, and there were people that had seizures around the campfires, and they were often, for whatever reason, women, would fall into the campfire as they're cooking, and no one would pull them out. So they had terrible burns all over their body because no one wanted to get this infection called epilepsy. So this is a video that's obviously been done in a first world country. And that woman, she could be walking down the stairs. She, and suddenly something like that occurs to her, and she can have some serious injuries just from a seizure occurring. So if anybody has anything to ask, inviting any questions. So that was an example of a generalized seizure. And more specifically, if you saw that, it was called a generalized tonic-clonic seizure. The very first thing that she had was she had tonic stiffening of her arms. And then as the seizure progressed, she started to have clonic movements, meaning that there was convulsing, shaking movements that occurred. And then with time, those shaking movements become less and less frequent, and then it eventually stops. And that's a normal pattern for a generalized tonic-clonic seizure. So now I'm going to show some videos of focal seizures, or two focal seizures. And when a person has a focal seizure, the manifestations, the clinical manifestations of that seizure, always you have to think about the clinical manifestations are determined by where in the cortex that the seizure started from. So if it occurred in the occipital cortex, the initial manifestations will be some change in vision. Typically, they'll be sparkling lights or a loss of vision in one visual field, either to the right or left. And that might be the extent of their seizure. They could just be seeing sparkling lights and thinking it was a migraine aura or something like that. But then that same person with an occipital lobe focus might just one day have that migraine aura type symptom, and then have a generalized tonic-clonic seizure afterwards, and that makes everybody then think that maybe those things that were called migraine auras were not really migraines at all, they were all little focal seizures. So this is the point is that, once again, the symptoms stem from where the epileptic focus is occurring. So if it's in the occipital lobe, it tends to be the visual symptoms. If it's in the parietal lobe, it tends to be sensory symptoms. If it's in the frontal lobe, it tends to be motor symptoms. If it's in the temporal lobe, which is probably the most common cause of a focal seizure, they often tend to be psychogenic type symptoms, like dreamy states is a common symptom. A sense of deja vu will be the initial manifestation of their seizure. And so I'm going to show a video of a patient who had a seizure stemming from their temporal lobe. So once again, she's in the telemetry unit. So she feels something happen. She's pushing the button to alert people that there's something abnormal happening. And if you asked her afterwards, what did you feel? She'd probably say something like, I felt a dreamy state, or I felt some unusual sensation all over my body. And then her friend is there with her. She's trying to interact with her. And she's not there right now. Now what you're seeing is that seizure has spread to the opposite hemisphere, and it's generalized, and very similar to the last person, she's starting to have a generalized tonic-clonic seizure. So this typically lasts 95% of the time. A seizure will last from a minute, 2 minutes maximum. Sometimes, however, seizures don't stop after even 2 minutes. And they can present to a hospital after having had seizures, having had a single seizure lasting for several minutes, even hours, and even days. And if that occurs, they need to be in a intensive care unit, to be intubated, and really it often becomes difficult to stop those seizures. So that's an example of a temporal lobe seizure. Here I'm going to show not a grainy video, but of a frontal lobe seizure. So as we'd expect, it's a frontal lobe seizure. There should be a lot of motor manifestation, movements. So if you talk to her, she probably wouldn't be there right now. She wouldn't be even on the phone. And the person who's at her bedside is trying to inject a radioactive tracer to eventually do what's called a SPECT scan, a nuclear medicine scan, that would help you define where the seizures are coming from in that person's brain. But what I really wanted to show you here was that on the EEG, you see this oscillation that's occurring consistent with a seizure. So next type of seizure, I'm going to take a look at this, and you tell me what type of seizure that would be. Anybody? So yeah, so you would think that, if anything, was a frontal lobe seizure. And if I didn't have an EEG on that person's head this time, I would have said, you know, it very possibly is a frontal lobe seizure. But to define that better, we had the EEG on, and in fact, you don't see the same level of synchronous oscillation in this person as you saw in that last person. And in fact, this person's having what's called a psychogenic seizure. So this is completely psychiatric. And it happens quite often that we have to admit these people to a hospital to try to define whether these events that seem to be coming out of the blue of seizing the patient are epileptic or not epileptic. And so that person, the typical story would be something like the patient was abused in childhood or later on in life, and for whatever reason, sexual abuse tends to be very common. And then years later, was being followed by a psychiatrist for their post-traumatic stress, and suddenly started manifesting those things. And had seen neurologist after neurologist who had started them on medications for epilepsy. None of them had worked. And eventually, the patient came to the hospital and was admitted to the telemetry unit, EEG unit. And we could see that they weren't certainly that would not be epilepsy. So along the way, I'm using some terms. I just wanted to define these for you. Seizures can be defined in themselves as simple or complex. And if I ever say the word simple seizure, that means that there's no alteration of level of consciousness in that patient. So some people with frontal lobe epileptic focus, they could just have something like this happen. And it could last a couple of minutes, and they could talk to you, and they could say, yeah, my arm is shaking, I can't control it at all. And that could be the extent of their seizure. However, if the patient's level of consciousness starts to become impaired, that's when you start calling it a complex seizure. So that temporal lobe patient, she's sort of dreamy after she pushed the button, and during that dreamy state, her friend would have tried to talk to her, and she wouldn't be there. And she wouldn't remember anything that her friend had said to her either. So these terms are used together. A simple motor seizure, this is something, my arm is shaking and I'm still able to talk. A complex partial seizure would be this temporal lobe patient who's having these dreamy states and is unable to interact during that state. And then some other terms that I might use along the way, and I just wanted to define for you here. It's convulsive, means that there's some involuntary muscle contractions. Non-convulsive means that there's no muscle contractions at all. So for example, that patient who had the very first video I showed you, the patient who had the generalized tonic-clonic seizures, that person would be having convulsions. The second video that I showed you, where the woman pushes the button, she had no discernible convulsive movements until later on during the seizure. So initially it was non-convulsive and later became convulsive. So the question, does a simple generalized seizure exist? Anybody? Yeah, so no. So if a seizure becomes generalized involving both hemispheres, the areas of consciousness stemming from the reticular activating system are impaired, and the patient will not be conscious. So the second part of this talk here, I'm going to talk about some models of epilepsy. Any questions? So epilepsy occurs because of, and I put this together as one of 4 abnormalities in a person's brain. So you can have an intrinsic disequilibrium of the normal balance between cortical excitation and inhibition. So all of our brains are maintained in some level of balance between excitation, brought on by mostly the glutamatergic glutamate system, and inhibition, which is the GABA system. And so if there's too much glutamate in a certain wide area of the brain or a small focal area of the brain, that person is more prone to having seizures. Another common cause of epilepsy is a structural abnormality of cortex acquired during embryogenesis, and I heard from Dr. Bowlby that he talked a little bit about that. So as I was mentioning, epilepsy stems from a problem of the cortex. If the cortex is not organized properly, those people tend to be more at risk for epilepsy. The third common cause, and actually probably this is the most common cause, number 3, it can stem from a structural abnormality of cortex acquired following embryogenesis. So as I was mentioning, seizures are a symptom rather than a disease of its own. And people who have a stroke that involves their cortex. Would everybody know what a stroke is?
We didn't cover stroke.
So, yeah, so there are two main causes of a stroke. There's either a hemorrhagic stroke or an ischemic stroke. So if all of a sudden in front of you right now, one of my blood vessels in my brain popped because, for example, there was a weakening of an artery in my brain, in the arteries of my brain, or my blood pressure was just way too high. That would cause bleeding inside of the brain, and that's what we call a hemorrhagic stroke. If, however, I had a problem with my heart, for example, for whatever reason, my heart wasn't contracting properly, and this abnormality in my heart contracting predisposes for clots to actually form inside of my heart. One of those clots could actually shoot off out of my heart, up through the arteries of my neck, into my brain, and I could have this clot embed itself within the arteries of my brain and cut off all blood to the area that would be supplied from that artery. So that would be called an ischemic stroke, or what's called brain ischemia that occurs in the territory that is supplied by that artery. So a common cause of seizures, especially in the elderly, is that they will say that they had a stroke years ago, and then later on in life, a couple of years later, they started having focal seizures. But it wouldn't, there's a lot of different reasons for having a acquired abnormality of the brain later on in life. I could have had a head injury earlier on in life. I could have developed some malformation of a brain vessel, vascular malformation. And all of those things, as long as they're causing an abnormal cortex, any of those things could cause epilepsy and seizures. So, and then the last cause of epilepsy that I wanted to talk about here is that epilepsy can be caused by a dysregulation of a physiological neuronal network. So, for example, one of the most common causes of epilepsy in childhood is called absence epilepsy, or the name of the disease is childhood absence epilepsy. And the networks that are thought to be important in childhood absence epilepsy are the same networks that we all have that cause us to have a sleep-wake cycle. So once you start going to sleep, there are certain systems in your brain that we're going to talk a little bit about later on that come into play that cause a normal synchrony of cortical activity in the brain that results in you having a depressed level of consciousness and then sleeping. However, if all of a sudden those same networks became abnormally controlled, all of a sudden you could have behavioral manifestations that are called absence seizures or absences. And so very often you'll be children who are sitting in their classroom watching their teacher, 7, 8 years old, and the teacher might just think that this person, this little child was a daydreamer. They might just be all of a sudden just staring off in space for 5 seconds, maybe blinking a little bit, and then they come out of it. But if those things are happening so often that the child is no longer able to follow the lesson, that same child might have a regression in their schoolwork. That is often the scenario that Dr. Bolduc would see in his clinic, is some child who the teachers finally clued in that these staring episodes is not just a daydreaming child. There's something more to it. So once again, I just reiterate here, epilepsy occurs because one of these four things: an intrinsic physical degree of a normal balance between cortical expectation and inhibition. And those tend to be patients with channelopathy and that are genetically based. Epilepsy can occur because of a structural abnormality of the cortex acquired during embryogenesis. So those are often malformations of cortical development. They can occur because of a structural abnormality of cortex acquired following embryogenesis. Lesions, such as lesions I mentioned, like a stroke, or a traumatic head injury. And then the dysregulation of a physiological neuronal network. Often this is seen in absence epilepsies with a distortion of the normal sleep wave subject. So to review, a few things here. Just hope you remember about how an action potential is formed, so that there's an electrochemical gradient in the neuronal formation. And an action potential occurs at the axon hillock and travels down axons, resulting in fast opening and closing of voltage-gated sodium channels and slow opening of potassium channels. And so neurons communicate with one another via neurotransmitters released across the synaptic cleft, which attach themselves to specific postsynaptic receptors. And depending on the neurotransmitter, a graded excitatory or inhibitory postsynaptic potential is formed. So at a molecular level, epilepsy can occur because of, as I mentioned before, a disequilibrium between excitation and inhibition. So excitation is mostly mediated by the brain, and inhibition by GABA. And if you have too much excitation or too little inhibition, that person is prone to having seizures and therefore epilepsy too. And not surprisingly, what do we do when a person has epileptic seizures? For all types of epileptic seizures, we try to give them medications that reorient that balance between excitation and inhibition. So we tend to try to either increase the GABAergic system, and there are a huge number of medications that are used for that, or decrease the effects of the glutamate system. And as Dr. Bolduc briefly mentioned at the very beginning here, channelopathies causing epilepsy is an exploding area of epilepsy research. And there are numerous genetic defects that have been described in the past 20 years. And in fact, this is probably about 20% of all the genetic epilepsies that have been described related to channelopathies. So these are usually genetic abnormalities in either the postsynaptic receptor or the ion channel that communicates with that receptor. And I'm going to give you a clinical example of one of these. So there's a very interesting epilepsy syndrome, which is called severe myoclonic epilepsy of infancy. And it's also called Dravet syndrome by the person who first described it. And the clinical phenotype, or the description of this syndrome, first occurred in the 1970s. And it starts off with babies in their first year of life who were previously developmentally normal, and then usually following a fever. And as I was mentioning, fevers can be provoking factors. So if I heated anybody up high enough, they would have a seizure. Usually following a fever, babies develop hemi, which means half of the body, clonic, convulsive movements. Or they can have hemiclonic movements and then generalized tonic-clonic seizures. And usually these seizures recur within months after that provoking fever. And within 1 year, those children who were doing really well and they were sitting up at the normal age, they were smiling at the normal age, they were rolling over like they should have been, they start developmentally regressing. Or they just don't attain the developmental milestones that you should in that second year of life, third year of life, etc. And so usually in your second year of life, you're not, you start talking, and those children just don't talk. And then those children often survive into adulthood with intractable epilepsies. And usually they have generalized tonic-clonic seizures very, very frequently, and you get them loads of medications, and none of these medications tend to work very well at all. And they are severely developmentally delayed. And then over the last 10 years, Dravet syndrome has been associated with over 100 different mutations in a sodium channel encoded by the SCN1A gene. And sort of interesting is that they found that this mutation in the sodium channel causes an epileptic seizure. So, but I said to you guys that we're trying to, that seizures occur because of either too much excitation or too little inhibition. Well, sodium tends to be something that causes excitation, depolarization of the cell. So how can the mutations of the sodium channel cause epilepsy? Well, it's thought that these sodium channels are expressed primarily on cortical inhibitory interneurons. So in fact, you can see in this sort of situation where neurons are working within a network of other neurons. If neurons that are mainly inhibitory ones are primarily affected and they're being knocked out, that in that network scenario, these people would be more prone to too much excitation. And therefore, causing excessive excitation, altering that balance between excitation and inhibition, and causing those people to be more prone to developing epileptic seizures. So this brings to a... Yeah, so for whatever, it's not always a fever, but it tends to often be the case that the very first seizure is related to a fever. And as I was mentioning, the fevers are provoking factors, and anybody who has a high fever has what's called a lower threshold for a seizure. So that person might be, that baby might have been fine, and with a tendency towards epileptic seizures, then you give that person a little cold, upper respiratory tract infection, they have a bit of a fever, and then they have a seizure, but and just later over time, then they start occurring not only during times of fever, but at other times too. So, which brings to a really very interesting study that came out in the last couple of years. And I think I added this to the package that we look at. And it's a phenomenon called vaccine-induced epileptic encephalopathy. And so there have been causal claims by parents and physicians of vaccine-induced neurological dysfunction for many, many years. So probably your parents had some thoughts about whether they should give you a vaccine or not, because you've heard through the press that autism can be caused by the measles, mumps, rubella vaccine. And shortly thereafter, in the next days or weeks, they do something funny, and they might even have a seizure in the days after a vaccine. And so physicians had described over the years a vaccine-associated encephalopathy. And it's similar to this alleged association between autism and the measles, mumps, rubella vaccine. They talked about a vaccine-induced epileptic encephalopathy associated with pertussis vaccination. And something you should know about pertussis vaccination, for whatever reason, all of us have a fever after pertussis vaccination. That's just something that happens. And so physicians talked about how they were seeing loads and loads of epilepsy and developmental delay after pertussis vaccination. And they thought, well, there must be a cause there. And then in 2006, a researcher in Australia, he gathered 14 cases of patients with so-called vaccine-associated encephalopathy. And he examined these patients' DNA for this SCN1A mutation that I talked to you about before. And lo and behold, 11 of those 14 patients had a previously described SCN1A missense or truncation mutation. And he later showed that the severity of epilepsy and intellectual handicap was no different than patients with Dravet syndrome. So in fact, all of these cases that people were reporting, physicians had diagnosed as vaccine-associated encephalopathy, were in fact not vaccine-associated encephalopathy at all. They just hadn't tested the right gene. And so probably those three left, the rest of those 14 probably have some other mutation that's never been described before. So the idea there that I guess it's a lesson to us all is to be humble in our diagnoses. So a second cause of epilepsy I wanted to talk about are malformations of cortical development. So I understand that you've learned a fair bit about embryogenesis. So during the first 2 to 4 months, in that gestational age, there's neuronal proliferation in the ventricular zone here. And then at gestational age 3 to 5 months, neurons start migrating along radial glial cells to more external locations and start forming the cortex. And then later on, at 4 months, even 2 years, those neurons that are now at the cortical level start forming interactions between themselves and forming networks. And there are many types of malformations of cortical development that can occur, and they're common causes of both developmental delay and epilepsy. And these malformations can occur at any of those 3 stages of cortical development. So if there's an abnormality in proliferation, the brain is shown here in the MRI. It's called a lissencephaly. So the brain is actually very smooth, and there's hardly any neurons in the outer layers of cortex. If there's increased proliferation in that ventricular zone, they get what's called a megalencephaly. So this is an example of a hemi, so half of the brain, megalencephaly. So you can see that the left side of the brain, for whatever reason, radiologists always flip these things around so that the left side of the brain is on the right side of the picture. So this person has a hemimegalencephaly on the left side of the brain. And then you can can also have a localized increase in neuronal proliferation, resulting in what's called a focal cortical dysplasia on the top right there. So abnormalities of neuronal migration could result in what's called a periventricular. So if you remember your anatomy, but these are the ventricles there, and this would be an axonal cut in the person's brain like this. Versus this would be what's called a coronal cut, which is essentially slicing the patient's brain up, down, like that. So a periventricular nodular heterotopia is where there's this localized area of neurons that fail to migrate to the outer layers of cortex, and it remains near the ventricles. And more impressive looking neuronal migration defect related to impaired migration is shown on the bottom here, where this person has what's called a subcortical band heterotopia. So if you look at the MRI, you can see that this patient has normal cortex along here, and then there's this, and that would be this darker gray as opposed to the lighter gray underneath it. And then, but under here, there's a shadow of gray, and that would be cortex as well. And in fact, this shadow on the other side is also cortex. So they have some of their neurons that migrated normally to the outer layers of the brain, but some of them just sort of stopped right in the middle. And all of those people, as I say, are very commonly have that. And now disorders of neuronal organization can also occur. And on the top here, there's an entity called polymicrogyria. So that there's some tiny little microgyri, small little gyruses, and in a very focal area. And then a really impressive one is called a schizencephaly here. For whatever reason, the connections between a whole area of one hemisphere can cut off as well. And all of those would be examples of neuronal migration defects. So what caused these abnormalities in embryogenesis? Well, there are a huge number of causes. Some of them are genetic, and some of them are acquired. We now know several genes for various cortical malformations, and they tend to encode proteins involved in microtubule stabilization. But there are other causes other than genetic abnormalities, and they can very often be things like prenatal infections, so an infection inside of the mother's womb, and for whatever reason impair embryogenesis if that infection occurred at a crucial time. An embryo that had a stroke, for example, for whatever reason, could have a malformation of cortical development. And often we just don't know why that baby developed this malformation of cortical development. So why are these lesions epileptogenic? And the best explanation that I can come up with is that there are local distortions of circuitry. So as I was mentioning, that the brain conceptually has this normal balance between excitation and inhibition. And the brain has to have fail-safe ways to make sure that there isn't too much excitation and therefore a seizure development. So that there's normally brains and neurons in the cortex have circuits that feed back upon themselves to have feedback inhibition. So So in the top right-hand corner, I showed a cartoon of excitatory neurons that would be would be white, with their cell bodies in white, and inhibitory neurons with their cell bodies in black, interacting with one another. And if you see that there's the excitatory neuron interacts with an inhibitory neuron to feed back upon itself so that there's not too much excitation. But what if there's a distortion of this normal pattern of feedback inhibition? Well, the example is the cartoon below, where there'd be an unstable epileptogenic circuit, where there's, on that middle neuron, there'd be very little to prevent that neuron from just exciting itself and exciting its neighboring neurons over and over and over again. So that person would be more prone to seizures from that area. So again, to put this in some type of clinical context, because it's fun, is that focal cortical dysplasias is a very common example of a malformation that's seen in epilepsy. And patients usually present in the first or second decade of life. They usually have mild or no developmental delay, but frequent seizures. And their seizure types are dictated by the location of the dysplasia. So once again, if it's occipital, they tend to have visual symptoms as their seizures. If it's frontal, they tend to have motor manifestations as their seizures. And sometimes only something very subtle on imaging is eventually picked up. And MRI is an imaging modality that's actually progressed very, very well over the last 20 years. And so if a person's had an MRI 10 years ago, for example, we often, and it was called normal, we'll often pick out some subtle abnormality of the cortex now that was never picked up before, and a good explanation why that person is having recurrent unprovoked seizures in epilepsy. Those patients with malformation of cortical development, there's an example of an EEG, and they tend to have this very, very active, spiky, looking EEGs, and all of those little spikes there are signatures of epilepsy in that little area. The treatment of these epilepsies are often resistant to anti-epileptic medications. Is not a surgical epilepsy talk too later? So they oftentimes the only way to cure the epilepsy is to actually take out that area of the brain and hopefully cure the patient from their seizure, meaning maybe later on get them off of all medications. So it's important to make that diagnosis on the MRI. So a third model of epilepsy, and I talked a little bit about this, are acquired epilepsies. And so once again, almost any process that permanently damages cortex can be a cause for the cortical epilepsy. Common acquired epilepsies are strokes, vascular malformation, tumors, traumatic brain injuries, or other causes of scars or sclerosis. The most common focal epilepsy, in fact, in North America is what's called mesial temporal lobe epilepsy. And so, just to review the anatomy, the mesial temporal lobe comprises the amygdala, the hippocampal formation, and the parahippocampus. These structures form part of the limbic system and are important in laying down memories. And the hippocampal formation consists of the dentate pallus, the hippocampus proper, the subiculum, and the interleural cortex. And the hippocampus proper has 4 different areas, and they're called 1, 2, 3, and 4. And unfortunately, this hippocampal circuit, important for laying down new memories, is particularly prone, as I'll show you, to forming seizures too. And the reason for that is that there's a very important feed-forward excitatory pathway, so-called perforant pathway, where the entorhinal cortex, here, EC, excites the neurons in the dentate gyrus, and then neurons in the dentate gyrus extend from the granule cells to the CA3 and CA4 area of the hippocampus, and they interact with pyramidal cells in the hippocampus. And CA3 and CA4 pyramidal cells excite other pyramidal cells in the CA1 portion, and those CA1 portions feed back to the excite neurons in the cerebellum and the entorhinal cortex. So there's this entire pathway where each neuron is feeding forward onto another neuron that excites a neighboring neuron, and then that feeds back to excite itself too. So it's an unstable circuit if there are no checks and balances. And so the main check and balance are related to inhibitory interneurons in the dentate gyrus, and they provide some control over the circuit. Now, neurons in the mesial temporal lobe are unfortunately particularly vulnerable to damage from times in early life. And so they're, for whatever reason, I don't know if we know why, they're particularly prone to damage from toxic injuries, from infections, or even from prolonged seizures. So there's, you talked a little bit about neurotoxicity, glutamate neurotoxicity. So unfortunately, just if you have too much glutamate in an area, the glutamate causes opening up of calcium channels, and that calcium can actually destroy the neurons itself. So prolonged seizures in themselves can damage neurons. And so these, in the mesial temporal lobe, there are epileptic changes that occur under these clinical conditions, and they cause selective neuronal loss in the CA1, CA3, and CA4, really more CA4, and inhibitory interneurons in the dentate gyrus. And so that importantly, as you can see, that pathway that was supposed to cause some control over this feed-forward system of excitation now no longer is causing any control over that system. And now that circuit is inherently unstable. And so the clinical scenario that often results is what's called mesial temporal lobe sclerosis. So that, as I mentioned, that term sclerosis just means scar. And these patients often have a history of seizures early in life. They could have had a prolonged seizure related to a fever as a child. They had long generalized tonic-clonic seizures. And later on, the seizures stopped, and then years later, that patient developed epilepsy. And they developed the term complex partial seizures, or another, i.e. focal temporal lobe seizures. So on the MRI, and I would only end up seeing these people, the earliest I would see them was 17 years old. And I would do an MRI on these people, and they will have scarring of their mesial temporal lobe. So this, again, is a coronal cut. And if you compare the two hippocampi, you can see that this side is a little brighter than that side. It's actually not a little brighter.
very much brighter than the other side. And that's a picture of what we see as a little scar involving the campus. So that same patient who's developing recurrent unprovoked seizures or complex partial seizures, and actually very often has memory problems too. On the EEG, just over that temporal lobe, just for your interest, we would see signs of epilepsy just over the electrodes of the temporal lobe. And during seizures, you might actually see rhythmic activity on the EEG associated with the temporal lobe seizures. Now, the treatment is initially an anti-epileptic medication, but once again, these people very often don't respond very well to anti-epileptic medication. And Dr. Wheatley is going to, a surgeon, is going to talk to you about how they often go on to have surgery to take out their temporal lobe. And it's not an easy job that he has, where he's telling people that he's going to take out their temporal lobe. And sometimes that's going to cause more memory problems, but it has a chance of curing your epilepsy. So the last model I'm going to talk about is absence epilepsy, or this dysregulation of a physiological and neuronal network. So here, I'm going to show you an example of a patient having an absence seizure. So better to look at the bottom image video on the left, or sorry, on the right. And all of a sudden, he just looks like he's stopped interacting, and then he just suddenly wakes up again. And that would be an example of an absence seizure. And actually, for reasons that they're not entirely clear, that person, right after they wake up, they're completely back to normal, as opposed to most other seizures. It takes them a little bit of time until they get to a normal level of consciousness. Absence epilepsy is also called petit mal epilepsy. It's an old term that we really no longer use. So you'll hear about that or read about that somewhere. And it's a common cause of epilepsy in previously healthy children. The scenario usually is birth and have normal development and no other past medical history at all. And they start having seizures in their childhood and adolescence. And those seizures would be absence seizures, where they suddenly stop whatever they're doing, and they could just be staring and have some, or their eyes can be closed, and they can have some eyelid fluttering, and it typically lasts for 5 to 10 seconds, and then it ends. Often these children are thought to be daydreamers in their classes, as I was mentioning before, and they start performing poorly in school. And their imaging, no matter how many times you would image that person, with the best techniques that we have now, their MRI will look normal. But when you do an EEG on them, during one of their events, the EEG shows this characteristic synchronization everywhere over the brain. Clinically, they tend to be actually very nice patients to have because their seizures respond usually very, very well to medications. And sometimes these people will grow out of their epilepsy by the ages of 18, 19 years old. But sometimes they require lifelong medications. And in this scenario, there's no role whatsoever for a surgeon. Now, the pathogenesis of epilepsy, of absence epilepsy, is something that people debated for decades and decades. And I think there's still some people who debate it. And it's a distortion of a physiological thalamocortical network. So, as you know, the thalamus has interactions with the cortex. And the there are cells in the thalamus that are called thalamic relay neurons, or TR. And they have widespread connections with areas of the cortex. And thalamic relay neurons have two main firing patterns. They can be firing all the time, regularly, or they can be firing in bursts. And then fire quickly, and then stop for a while, and then they'll fire again. And we know that that tonic activity of a tonic mode of thalamic relay neurons firing is associated with wakefulness, and that bursting mode is associated with sleep. Now, the control of these modes between the tonic mode and the burst mode occurs by interactions with other neurons in the thalamus called the nucleus reticularis thalami. And there's the pathogenesis of absence epilepsy is that there's some dysregulation that occurs in this transition from the tonic mode to the bursting mode of these thalamic relay neurons. And so there's probably some abnormality at this level of the circuit, which causes these people for out of the blue to develop a disordered state of consciousness that is called an absence seizure. So it's really using the same pathways that we all use in sleep, but it's the regulation of these pathways that's abnormal. So that's the end of my talk here. I'll just put a few summary slides together for you here. And that's that epilepsy is a common neurological illness with considerable morbidity. I hope I convinced you of that with the videos of seizures. Epilepsy is characterized by seizures, but not all seizures occur because of epilepsy. Seizures in epilepsy have a varied appearance, and they're related to the locations of the synchronously firing neurons. Epilepsy occurs because of a localized or global imbalance between neuronal excitation and inhibition. And epilepsy can be quite genetic, often related to channelopathy, related to errors in cortical malformation during embryogenesis, related to cortical lesions acquired later on in life, or they can result from dysregulation